안녕하세요. In this chapter, I will talk about three articles: Myofunctional Therapy, MFT. Myofunctional Therapy, MFT, abstract, aim and objective, background, what is the tongue thrust, when to correct tongue thrust, review results, treating tongue thrust, discussion, conclusion, and clinical significance. In this article, Orofacial Myofunctional Therapy in Tongue Thrust Habit. Aim and objective. The respective review article is to provide an overview of the various exercises in orofacial myofunctional therapy as a treatment modality for tongue thrust habit. Tongue thrust can be treated in different ways with early diagnosis, removal of underlying causes, and correcting the tongue posture and breaking of habit with the use of orthodontic appliance. This review article is focused on the various OMT techniques employed for the correction of the tongue thrust. There are several exercises in OMT which can help a child with tongue thrust. What is the tongue thrust? Tongue thrust is a term that describes a swallowing pattern in which an individual pushes the tongue against or between the teeth. This habit has also been called defiant swallow, defiant deglution, and reversed swallow, perverted swallow, oral myofunctional disorder, visceral swallow, infantile swallowing pattern, and abnormal swallow. When to correct the tongue thrust. Tongue thrusting is normal in the neonate, in which the tongue lies between the gum pads and the mandible, is stabilized by facial muscle during a swallow. This gradually disappears with an eruption of the primary dentation. Normal mature swallow shows in the position of the tongue high on the palate behind the maxillary incisor and no lip and cheek activity during swallowing. A transitional swallowing pattern is seen in mixed dentation when some primary teeth are lost or permanent are yet to erupt or are erupting. This type of swallow is self-correcting. In case of one open bite, mostly greeted by habits like thumb sucking, the tongue gets thrusted ahead to achieve the lip seal. This type of tongue thrust is called simple tongue thrust. Complex tongue thrust is seen in individual with diffuse open bite, seen most commonly in mouth breathing, and child with history of chronic nasal-respiratory disease, allergies. Retarded infantile swallow is when the infantile swallowing reflex resurfaces after the eruption permanent teeth. This reviews aims to act reference guide for clinicians in listing the various myofunctional training methods for tongue thrusting habit. It's also described the patient selection for orofacial myofunctional therapy (OMT) and caution against the limitation of the same. All of these management strategies go hand in hand A habit-breaking appliance only attempted to block the heavy force of the swallowing, which even when added up only amount to about 20 minutes a day. Treating tongue thrust. Treating tongue thrust, management of tongue thrust included habit-breaking appliances like tongue grips act reminders and restrict the forward movement of the tongue. Correction of malocclusion and myofunctional therapy to correct the position of the tongue at rest and during the swallow. Myofunctional therapy. Official myofunctional therapy included exercise of the cervical and facial muscle for the improvement of uh, proprioception, tone, and mobility. Official myofunctional therapy is neuromuscular re-education of the muscle function to improve the function of swallow, tongue, oral breathing, and rest posture of the lips and tongue and cheeks. Official myofunctional therapy acts as an adjunct to orthodontic treatment and help in harmonizing of the orofacial function. It is included exercise that help with toning and resistance training of the orofacial musculature. Orofacial myofunctional therapy is tongue thrust habit um, adjusted to correct speech therapy and orthodontic correction of malocclusion. Orofacial myofunctional exercise for tongue thrust. Lip exercise. Lips, lips closure and competency exercise. Tightly closing the lips together. The child holds pieces of cardboard ice cream stick between the upper and lower lip for 5 seconds and repeat it 5 to 10 times. This will improve lip competency. Lip puffing exercise. The child is asked to force air in between the lips and teeth and puffing out the lips as much as possible, like figure number 1, lip puffing exercise. Lip movement and OE sound. The child is asked to spread the lips and piercing them as in excarted OA. Pallowing exercise. The child is asked to pallow into the ballon till it is full capacity, followed by letting on the air release and then repeat it again, like figure number 2. And bubbles blowing exercise. The child blows the bubbles from toys with the help of lips. Bottom pull exercise. A third is string the passage through a big button of about 2-3 centimeter. The patient is asked to keep the button between lips and teeth. The third is pulled out the same time the button is being held tightly in place by the lips. This improves the strength of the lips. 2 buttons can be used. One of the buttons is placed between the lips of the patient, while the other is held by patient outside. Whistling the child can be used whistle as prop or purist of the lips together for whistling. The whistling activates the perioral and cheek muscles. Lip stretching exercise. The patient stretch the upper lips in the down and out motion till it is maximum capacity. This is repeated 10 times. Variation of the same exercise is to hold the stretched upper lips down by pressing the lower lip against it for 30 seconds and repeated 15 to 20 times a day. This exercise improves the tones of the upper lip. Gum drop exercise. Gum drop exercise in which the large size gum drop is taking approximately 1 ounce an 18 to 20 inch string, depending on the height of the patient is taking. One end of the string is attached to the gum drop and other end is behind the teeth and held with the lips. The patient is asked to place his or her hands behind the back and bend forward till the face is parallel with the floor and the string is stretched. Then the patient asked to open his lips and stretch them as far down as possible, and the same procedure is followed 5 to 10 times a day. Cart pull exercise. Cart pull exercise. A piece of paper or cardboard is held tightly between upper and lower lip. The child tries to pull the cardboard in the outward motion. The lips try to resist the same. It is similar to tug of war and bottom pull exercise. Another exercise, drinking out of the straw, drinking from straw, and as the exercise that show high compliance with children, which aids in oral posture correction, exercise lip and cheek and tongue muscle. However, only a small segment. If the straw should be allowed inside the mouth, a lip block aids the activity where it is acts as a stopper. The impact of this exercise can be increased by using a twisted straw and a thick liquid like milkshake that demand more effort to suck. Another exercise, spoon holding exercise with the lip. The child is asked to hold the handle of the spoon between the lips, just like in the lemon spoon race, only this time the spoon is not held by teeth but only with the help of the lips. The spoon should be parallel to the floor as the uh, strength of the lips improves. The weight of the spoon can be increased and repeated 10 times. Exercise by wind instrument. They use the wind instrument like trombone, strengthening the lip muscles and assist in confusing the action of the tongue within the defined area. The supply of the blood to that part of the lips coming in contact with the mouthpiece improves due to stimulating effect. Regular and monitoring the usage of this instrument will result in improved tonality of the hypotended tissue and lengthening of the short, flappy lips. The position of the tongue during this usage of the wind instrument is high in the palatal, which is described as it stimulates tissue of the lower lips while reducing tension in the upper lips in the upper lip when the child play an other wind instrument like the flute. The upper and lower lips are engaged and thereby improve the strength and tone. Other lip exercise: suck the cheeks and lips to make lip look fish face and hold this position for 5 seconds. Hold lips into U shape. Open the mouth wide to open out the lips wide apart. Lip cases and make child line up a stuffed animal and kiss them all good night. Tongue exercise. Tongue spot: the child is asked to locate the spot behind the upper incisor on the palate. Hold the tongue at the spot for 10 seconds and repeat it 10 times. Tongue click: placing the tongue against the roof of the mouth at the spot. Snap it down to make a clicking or popping noise. Another exercise: swallowing thin liquid. The child to ask it to take some water in the mouth at the same time holding the tongue at the spot, not allowing the liquid to fall out the mouth. Hold 5 seconds and swallow. The same can be repeated by closing teeth together, followed by swallowing. In this case, the tongue surface touches the roof of the mouth. Swallowing thick liquid. Ask the child to take a sip of the thick liquid like milkshake and hold the tongue at the spot and not allowing the liquid to fall out of the mouth. Hold for 5 seconds and swallow. For S exercise, for S stands for spot and slipate, squeezes and swallow. The tongue is taken to the spot behind the maxillary incisor. Patient is asked to hold the tongue there as he slipate, followed by squeezing the spot and them swelling with the teeth together while maintaining the tongue at the position. It is advisable to follow this swallowing exercise at least 40 times a day to imbibe this new swallowing pattern. Touch a nose exercise. Touch a nose exercise involves the protruding out the tongue and uh, trying, uh, trying to touch the lip of the nose. This has to be held in this position for 10 seconds and repeated 10 times. Another exercise: touch chin exercise. In this exercise, the child is required to protrude the out of the tongue to try to lick the bottom of the chin. The position should be held for 10 seconds and should be repeated 10 times. Tongue sideways movement exercise. This exercise involves protruding the tongue out the moving it in extreme right and left direction. The tongue is to be held each direction for 10 seconds. This exercise is to be repeated 10 times on the each side. Tongue rolling exercise. In this exercise, the child is required to roll the tongue by folding its edge toward the midline, just that resembles to taco shell. In this rolled position, the child has to protrude the tongue out the maximum extent possible while holding it is for 10 seconds, and this exercise has to be repeated 10 times. Another thing is orthodontic elastic and swallow. This exercise is done with either number 5 or 6 elastic. The child is required to place the elastic at the lip as the tips of the tongue, followed by raising the tongue to touch the spot of the palate. This exercise is to be repeated several times while continuing to hold elastic at the spot. The child should salivate and followed by swallowing. Another exercise, hold and pull exercise. The hold and pull exercise is aiming to stretching the lingual frenum. In this exercise, the child is asked to slowly open the mouth while holding the lips of the tongue constant against the hard palate at the crest. K sound and swallow. This exercise involves the pronunciation of the sound k when the child say k the explosive way. The posterior part of the tongue touch of the soft palate and the tips of the tongue remains low. This create awareness of the posterior tongue action of the child. K sound and swallow exercise involves the first saying the k sound, followed by salivating and then swallowing. This refines the normal way of the swallowing for the child. Another hold of the tongue plates and wash the tongue. This exercise strengthens the muscle of the tongue and the throat. This is exercise of the child accepted keep it tongue plates, ice cream tricks, and the initial edge of the lower anterior teeth with 2 to 3 centimeter of the plate extended inside the mouth. Then the child is required to try and lift the tongue plate against the resistance of the firmly held plate, like figure 3 and 4. The tongue exercise using food reinforced. Any stucky food item can be placed either on the plate, in the vestibule corner of the mouth, or on the lips, or the child licks it off with the tongue through by increasing the tongue strength. For this exercise, peanut out butter or yogurt acts the good reinforcers. Tongue exercise using a spoon or any hard object. It is to be held front of the lips while the tongue washes against it. This has to be done for 10 seconds with the tongue steady and straight, and not allowing it to point downward. Complete 10 repetition of this exercise. Tongue retraction. In this exercise, the patient is required to touch the back of the tongue against the palate while holding it is in the position for a maximum 3 seconds. This activity is to be repeated 5 times at any given instant. Another exercise, tongue extension exercise. In this exercise, the patient is required to protrude his or her tongue in between the lips, maximum extent as possible, holding it constant at this position for 3 to 5 seconds. This activity is to be repeated 5 times at any given instant. Tongue pull exercise. Gently pull tongue outside and hold it with help of hands by applying light pressure. For rotation, pull your tongue left, right, up or down. Tongue around the word. The child is asked to move his or her tongue around the teeth in small circles, 4 5 around, building up 15 in each direction 5 times a day to strengthen tongue muscles. Tongue push up. The child push his or her tongue up against a spoon, pops sickles stick 10 times. She can try make the tongue move straight up. While doing this exercise, ask kids to look into a mirror to see either they are doing it right or not. Monkey face exercise. Ask kids to put their lips of the tongue over front teeth under upper lips. In this case of the full monkey face, more than a tip of the as the more than tip of the tongue. The tongue covers from the teeth below the upper lip. Hold it 10 seconds. This is fun exercise and strengthening muscle like figure number 5, the monkey face exercise. Orthodontic rubber band exercise. The first, place the orthodontic rubber band of the tip of the tongue. Place the tip of the tongue against of the roof right behind the upper front teeth. Occlude your teeth is a regular bite. Don't bite forward. Keep the lips apart of the swallow while keeping your lips apart of the teeth. Close it to set of the 30-second swallow practice are recommended every day. Lingual imitatory exercise. In this exercise, the patient has to protrude out the tongue and move it in different direction and speed. The first, the patient learn to move the tongue in various direction and practice holding it steady. The next level is to move it circular mutation and clockwise and anti-clockwise 10 seconds each. While improving the circular motivation, the tongue tip should sweep the feminine boards of the lips. The child can be improved this exercise with the help a mirror. The difficulty of this exercise can be increased by turning the lips outward toward the buccal surface and performing the circular motion with the tongue. Also another tongue exercise. Vibrating toothbrush. Vibrating toothbrush can be used to brushing teeth, and the vibration stimulates the tongue movement and acts as strong sensory input. Also, teeth counting exercise asks the children to count teeth with the use of the tongue. This helps by movement of the tongue in all direction and challenging yet funny exercise for children, like figures number 6, teeth counting exercise. Also, self realization and swallow lessons. The child needed to ensure that muscle used to facial expression and are not engaged to during swallowing. For the myofunctional training exercise listed here, the child should be made aware of the pre-oral mental and facial muscle contraction. And also air sucking exercise. In this case of children with open bite malocclusion and other partial, complete, or thrusting of the tongue sideways, open lips, tongue pack, air sucking exercise in the beneficial. In this exercise, the child has to close the back teeth tightly together, open his lips wide, and sucks in air vigorously. At the same time, the tongue is to be thrown back such that the tip of the tongue touch the back of the palate ridge, followed by swallowing. The mirror should be used to ensure the tongue is pulled back and stay in the same position without touching the teeth at any point of the time or place. Also, the bite and swallow procedure. The child is asked to bite the palpable rubber or Swiss soft tube, and then by making the click sound, patient is asked to bite and swallow. This activity is for improving masseter and temporalis muscle contraction. Cheek exercise. This exercise uses combination of water, tongue movement, and puffing to strengthen the cheek muscles. While holding the water in the mouth, the child is required to shift the water sideways. Alternatively, the patient can puff her cheek with air. The child shifts the air from one cheek to another while ensuring that no air escapes from the mouth or the nose. This is to be repeated minimum 5 to 10 times and should be performed 5 times a day. Rolling the tongue from one cheek to another cheek. Also, face exercise, puffing the cheek with air. The child should blow the fish face, repeating the activity 10 times at any given instant. Miscellaneous exercise and yawing exercise. Yawing, strengthening the throat muscle. It's pull the tongue backward and upward, and also toward to back of the thrust. Mirror exercise for the soft palate. Exercise of alpha while looking into the mirror is an effective way to improve the strength and tonicity of the muscle on the soft palate and the pharynx. Jaw exercise. Handheld messengers have to be the jaw for a few seconds at a time are known to stimulate the muscles or muscle of the mastication. Vibration is very stimulating of the short beauties and help in relaxing the tight muscles. Open the jaw wide and say ah, and hold for 5 to 6 seconds. Massage the jaw gently toward and away from the lips. Also, breathing exercise include the combination of the perineum and balloon blowing and water holding in the mouth, all while performing the breathing through the nostril activity for perineum or the air is inhaled and exhaled rapidly through the nose, keeping the mouth shut but relaxed. Balloon blowing exercise has a high degree compliance from child patient. A deep breath is taken through the nose and his air is exhaled into the balloon. The balloon is expanded to its maximum capacity by exhaling more, breathing into it. This can be repeated 3 times a day. Subsequences therapy after multiple exercise session, reminder signed and boarded can be act cuts for child to ingrain the correct swallowing pattern in the sub consensus. Discussion. Patient selection for orificial myofunctional therapy in the tongue thrust. Orificial myofunctional therapy is not indicated in tongue thrust in absence of the speech dental problem according of the authors, the proofing and masons. There are no common agreement in the published right age of starting OMT on the tongue thrust. Some pediatric dentists have successfully used more myotherapy in children under 10 years of age, uh, whereas some prefer waiting till 10 years of the age or more, as this could be spontaneous closure of the anterior open bite before starting OMT of the tongue thrust patient. It's important to make sure that any anatomical variation like tongue tie is corrected. The need for surgical reduction of excessive lymphoid tissue should also evaluated before initiation myotherapy. Number, duration, and frequency of session. A treatment program planned for any child should have maximum of 20 sessions. The first of the 10 sessions are dedicated for learning of the tongue posture. The next session help with monitoring with tough exercise. The myotherapy session should continues till the exercise are ingrained with the child subconscious. The duration of each session should last 30 seconds. The frequency of the visit can be weekly at first, followed by every 15 days and later every month. Limitation of orofacial myofunctional therapy. It is important to understand that OMT cannot replace orthodontic correction, nor does it bring about change in the morphology. It is concept of active exercise of the success, which depended critically of the motivation level and compliance of the children and their parent equally. Future scope the orofacial myofunctional therapy. Successful management of tongue thrust included OMTs requires that term approach. The term included the general dentist, orthodontist, and pediatric dentist, speech pathologist, and pediatrician as well. It will be critical to bringing the attention of the clinicians to the oral musculature and its functions, which will hold the key of the successful treatment of the oral function. The conclusion of this article, the artificial myofunctional therapy, defined it as the role of the management of tongue thrust and should be included as a part of a comprehensive treatment plan of the patient. It is make a patient aware to full treat rest position and dynamic position of the tongue and help to learn of the physiological myofunctional behavior. Clinical significance. Artificial myofunctional therapy in tongue thrust help to improve tongue evaluation, improve the tongue elevation strength, correct tongue resting posture, and correct tongue placement while swallowing, improve tongue motility, improve maxillary construction, prevent replace of a corrected malocclusion, and improve sleep disorder breathing. The second article, effect of myofunctional appliance on children with sleep disorder breathing. In this article, we will talk about two case reports. Sleep disorder breathing, STB, induces the dysfunction of the orificial muscle, leading to morphologic alteration of the face and dental malignment. Early diagnosis and treatment of STB is required in pediatric patients to ensure normal facial growth. Myofunctional therapy (MFT) as modality for the treatment of STB and prefabricated appliance can be used. Here, two cases: malocclusion of STB, in which MFT with prefabricated appliance was used for orthodontic treatment, has been described. STB was diagnosed based on the clinical symptom taken by interview and home respiratory polygraph. In the both cases, STB was improved using prefabricated appliance for MFT. However, the resolution of the crowding depending on the tongue on the degree of crowding. Effect of myofunctional appliance on the children with sleep disorder breathing. In this two cases report, we will talk about introduction and case reports and discussion and summary. Introduction. Sleep disorder breathing, STB, encompasses wide range of the respiratory disorders specific to sleep or experted of the sleep ranging from habitual snoring of obstructive sleep apnea. The STB is common in children as well as adults, with a prevalence rate of 3 to 35% for snoring and 1.2 to 5.7% for obstructive sleep apnea. Then through most pediatric obstructive sleep disorder are mild to moderate compared to adult type. Untreated pediatric STB can have adverse effect on cardiovascular, metabolic, and neurobehavioral development that contribute directly to reduce quality of the life. The therapy aims to correct tongue position and improve connection of orificial muscle in order to facilitate better the nasal breathing and lip competency. However, it is difficult for young children to follow complex myofunctional exercise, and oral appliance designed to MFT may help children to perform orificial exercise. In this case report, two cases malocclusion accompanying STP treating with a prefabricated appliance for MFT have been reported. Improvement of STP and tooth alignment was noted in both of the cases. Case reports. On extraoral examination for lateral profile was convex and lip incompetence was observed. Proclined in upper incisor, and another situation for this case. The first case is 7 years old girl visited the pediatric dentistry department with a shift compliant anterior teeth crowding, and BMI was in 10th percentile and corresponding to normal obesity with calculated BMI of 14. For diagnosis of STB and Betula MPR, which the measures AHI and average saturation of pre-continuous oxygen, was used for home respiratory polygraph and clinical symptom of STB taken by interview with the patient mother in home respiratory polygraph. AHI was 1.3 and average of SpO2 was 96.6% based on the interview. The patient and the patient of oral habits included mouth breathing and non-catechoronal paroxysm. According to the International Classification of Sleep Disorder, the patient was diagnosed with pediatric obstructive sleep apnea as AHI was above 1.0. And also in this case, an extraoral examination in the lateral profile was convex, and lip incompetence was observed, and proclined upper incisor, and also in the mean normal vertical growth, and class 2 skeletal tendency with mandible retruded in the relation to maxilla were observed. As for soft tissue analysis, the upper lip was protruded nasolabial angle 80.9 degree, and lower lip was retruded. The patient was diagnosed with class 2 division 1 consequent to STB. The patient mother was informed to the main purpose of the MFT was orthodontic improvement with consummated resolution of STB, also comprehensive orthodontic. Treatment could be followed by depending on the patient need to dental saturate. After consultation, treatment was initiated with myofunctional appliance EF line. The patient, and like figure number 1, the patient was instructed to wear the appliance daily for at least 2 hours during the day and overnight while sleeping. After 6 months treatment, U1 to SN reduced from 110.2 degree to 101.1 degree, and IMPA increased from 94.4 degree to 96.8 degree, like figure number 2, table number 1. Offer just reduced from 7.2 millimeter to 3.7 millimeter, and offer bite from 3.4 millimeter to 2.3 millimeter. Oral breathing referred to nasal breathing, and moderated lip competency with a decrease in bruxism are noted, like figure number 3. Extraoral visits before A and B and after C and D treatment in case 1. And intercuspid with between the central and dentogingival junction decidual canine to increase it 23.5 millimeter to 24.5 millimeter in maxilla, and from 19.7 millimeter to 20.8 millimeter in the mandible. There was no significant change in the bimolar width between the central dentogingival junction of the first permanent molar. Both upper and lower anterior crowding showed improved alignment, like figure number 4. Case number 2, 7-year-old girl presented at pediatric dentistry department of the treatment upper incisor crowding bruxism and showing problem PMI was in the 50 percentile, corresponding to normal obesity with a calculated PMI of 15.9. In this home respiratory photography, HI was 1.8, average in SpO2 was 96.2%, according to interview with the patient of the mother. Habits included the mouth breathing and nocturnal bruxism. Considering the AHI and STB symptom, the patient was diagnosed with pediatric obstructive sleep apnea. Oral in extra-oral examination, convex lateral profile and poor lip competence was observed. In intra-oral examination, the tongue thrusting with the anterior open bite was found. Cephalometric analysis referred to retroclined in upper incisor. In this case, also nasolabial angle and upper nasolabial angle was both reduced. The patient was diagnosed with angle class 2 division 2 malocclusion and had symptom of STB. The patient of mother was informed that MFT could be performed of the correction of the tongue thrust and the reduction of the STB in the faces. A treatment. Additionally, the MFT should be showing the orthodontic re-evaluation because of the insufficient space available for unerupted permanent teeth. The use of the myofunctional appliance for treatment was also successful, blended with the consent of the patient of the mother, and the patient was instructed to wear the appliance during at least 2 hours during the daytime and overnight while sleeping. After 6 months of the treatment, there was increased the ABDI from 73.3 to 77.5 degree, which within the normal range, like figure number 5, table number 2. Clinically, convexity of the lateral facial profile was also found to decrease. And figure number 6, bimolar width between the central of the dentogingival junction of the first deciduous molar had increased from 21 22.4 millimeter to 22.9 maxilla, and from 22.0 millimeter to 23.3 millimeter in the mandible. In the contrast, the bimolar width between the center of the dentogingival junction of the first permanent molars had decreased from 29.5 millimeter 28.3 millimeter in the maxilla, and from 31.3 millimeter to 31.1 millimeter. And this mandible, the mandible AHI had decreased and from 1 to 0.8 to 1.0 after 6 months of the treatment, and average SpO2 had increased from 96.2% to 97.3. Mouth breathing referred to nasal breathing and no cultural paroxysm, and this opinion, according to interview with the patient mother, STB was improved by MFT, but upper anterior crowding reminding the figure number 7. And this effort resolved the upper anterior crowding fixed orthodontic treatment with the premolar extraction was planned. Discussion. The present case report describe improvement of STB symptom after orthodontic treatment with MFT in 2 patients was with malocclusion and STB. For the treatment of STB, custom-made mandibular advancement device is representative appliance, and however, due to the rigidity, the firm growth of the jaw and the developing dentation may be impeded. In addition, the consistent relation in the hard to obtain them deciduous the deciduous teeth exploit during the mixed dentation, and the contrast of the prefabricated appliance should use it. The present report made the elastic reinforced the silicone, which can accommodate the dentation regardless of the exfoliation of the deciduous teeth. It also has specialized component of MFT, like tongue positioner and twin splint of the prevention of the muscular interferences. In the current 2 case, effect prefabricated function appliances were mainly confined to dentoalveolar region. In first case, proclined upper incisor were retruded and deep overbit decreased to normal range, but no significant skeletal effects were found. In second case, angulation of incisor were changed, but no significant skeletal effects were found. However, the treatment period was relatively short in both cases. Future research it is required to determine the long-term cephalometric result of each treatment. And these cases describe hearing, and the primary aims were to improve myofunctional disharmony, STB, and malocclusion. And this cases continues motivation to require them during the treatment process, because high level of compliance of key to success of MFT. In this case, AHI showed the decreased tendency and symptom of STB disappearing. However, in some cases where myofunctional disharmony of STB are improved. The summary: STB's early childhood can be adverse effect of the myofunctional balance, and It is associated with malocclusion. Orthodontic treatment alone does not coordinate of that this issue will be resolved of MFT, maybe calculated successfully orthodontic treatment and maintenance. The third article will talk about three-dimensional longitudinal change of maxilla and mandible morphology during the predental period. The aim obstruct. The purpose of this study was longitudinal analysis of morphology of maxilla and mandible over times infants using 3D surface and scanner. The material and method. 17 Japanese full-term infants participated in the study, and dental plaster models were calculated every 3 months from 1 month of the age to 12 months. The plaster models were scanned using 3D surface scanner to create 3D models, the arch width and arch length and arch angle and palatal width, depth and palatal area of 3D models were analyzed. Introduction. In this in place of there are almost of longitudinal study concerning both maxilla and mandible. It is still unclear to how maxilla and mandible grow during the predental period, and whether there is difference between the developmental pattern of the maxilla and mandible and the growth pattern of the dental arch during the predental period is not fully understood. Material and method. And this 17 Japanese full-term infants, although with no craniofacial deformity, 7 male and 10 female. And this dental model fabricated also every 3 months from the first month after the birth to 12 months. Purpose in this study analyze 3D morphology of maxilla and mandible over time in infants, and this study dental model measured and analyzed from 1 month to 12 months of age using 3D surface scanner. And landmark and reference plan. In this picture, figure number 1, 3D scanning dental blaster model model A, 3D model of the dental blaster model, showing the maxilla and mandible landmark of the palate and alveolar arch. The most anterior point of the incisive papilla of the midline of the crest of the alveolar ridge, and B, point of the each lateral success of crosses of the crest of the alveolar ridge. B, right point, and B, left point. C, the width point of the arch of the crest of the alveolar ridge, and right, so C, the point left point, and D, the most posterior point of the distal border of the crest of alveolar ridge. And the result, the arches, the change of the width over time, showing the figure 4, arch widths maxilla were greater than the mandible. However, dimension of maxilla and mandible and all area measured increases from 1 month after birth to 12 months. The market changes is observed in the period of the from 1 month after birth to 3 months and 6 months, and this time. All this width in 12 months on both maxilla and mandible significantly greater than 1 month. Point 1. Angle arch. The arch of angle showed the market change between 1 month and 3 months of mandible. Figure number 6. The arch angle uh, decreases and the arch angle decreases significantly between 6 months and 9 months in mandible, with the arch angle growth in maxilla was less than mandible. Depth, palatal depth, the figure 7, change over time in palatal, and figure also number 8, in the contrast of the change of other parameters, the palatal depth was almost unchanged from 1 month to 12 months. No significant difference were found in the palatal depth between any time of the period. Conclusion: in this study, dental models were measured and analyzed longitudinally from 1 month after birth to 12 months of the age of using 3D surface scanner. Morphological analysis reflected that arch width and length of maxilla and mandible increased, while the arch angle decreases. The arch width, length of maxilla and greater than all this mandible, and the palatal alveolar ridge increased size from of occlusal aspect, with market growth in the sagittal direction. The palatal depth remained essentially unchanged, but the palatal area increased of the rest of the result of buccal growth of alveolar ridge.